Given that the diabetes is such a growing problem, both with children and also with adults, and that's across the world, but Australia is no different, do you think it's an area that we possibly could develop a real life helping? What about putting together a plan where we can actually help them through their life and we actually charge them a fee for service that isn't necessarily coming from the government, but we're actually justifying it by providing a quality product and or service that actually makes their lives better?
Community pharmacy is a fantastic place to deliver health. It's, people love pharmacists. They feel comfortable in your pharmacies. You usually know them. They're very accessible. And I think things like that will be great. And I think there will be a really good uptake by patients, depending how you sell. And yes, you're going to lose some because of price competition, that's great. But I think there's a whole lot of people that are willing to do that. And I think diabetic patients and chronic conditions, by definition, are chronic. Now, whether you're charging capitation fees or fee for service or whatever it is, the opportunity is there. And you get good clinical outcomes as well.
I understand that it's not about putting staff off. I get that loud and clear. But the wonderful thing, how many staff have you been able to put on? We're considering young pharmacists and, there's a new wave of education. What an opportunity. How many staff can you put on?
Exactly, yeah. Well, we actually have put on two young pharmacists within the last 2 years that have started, and their brief is to mainly do those sorts of services.
And did you charge your patients for the extra service?
No. We just got before the cap, all of this was all put in place before they put the cap. Still, you can do them. It's a better and more cost-effective form of advertising, depending on what you want your offer to be. I mean, if you want to sell detergent and coffee and vitamins at half price, then that's fine. But that costs you a certain amount of money a year to do that. But if you want to sell yourself as a quality healthcare provider, that's a really good form of advertising. Do 10 on the government and do the rest for nothing.
I was just wondering what your feedback has been from doctors, good, bad or otherwise.
I've got one doctor in particular who sat me down and talked to me for about 15 minutes about making an 80-year-old patient do all of those blood tests. And I suppose it's a matter of not being too gung-ho and sort of reading the situation. Does it really matter what an 80-year-old's, if he's within parameters, you don't want to get too specific. But once they see the results and once they see how engaged the patients get, it can be really good. They're more likely to sit up and take notice of it.
But I think you've got to build up to that, and I think the worst thing is starting these services without actually telling people that you're going to do them. And what we're seeing is that, there's a few doctors don't like it, but generally speaking, you're helping the patients, you're helping them manage the patient. You're not actually affecting them economically. You might actually be increasing their economics because you're sending the patient more often. So it's about working slowly over time and developing these relationships, particularly if you don't have a relationship before. And that's the critical thing. It's not just going gang-ho and saying, we're going to do this tomorrow. It's about engaging them really early, and some of them will hate it and others will go with you and start with the ones that go with you.
We find we do a lot of their diabetes education for them too, because, the nurse will give them the meter and they'll come to us and say how we use it. And that's a really good that's a really good place to start.
Medical practitioners have a program where they also claim for chronic disease management,
yes,
which involves diabetes.
Yep.
How have you encountered any resistance to communication between yourself and the medical practitioners, with a view that they might feel you're encroaching on their territory and they cannot then claim as part of their chronic condition management and probably fear that something like the same issues as the vaccination program?
Their chronic condition management, they can pick their allied health, and you can either have a HMR from a pharmacist, or you can do a diabetes educator, or you can go to the podiatrist. So they've got control over that, and they get paid for that regardless of where the allied health goes, because this is completely non-initiated by the practitioner. But I think it's mainly just in the collaboration that we're doing together. Then after that, there's no official payment for either doctor or pharmacist. It's just professional collaboration after that.